Atopic dermatitis, or eczema, is something we shouldn't need to see in the emergency department, right? After all, it's a chronic condition, and it's better managed with longitudinal care by someone who knows the patient well, right? I knew you weren't buying any of that. It's a frustrating condition with frequent flares. Patients can't sleep or even relax enough to eat, and caregiver stress and overload is common. Access to primary care is tough. Add to that some of the uncommon but dangerous complications of eczema, and you've got yourself a fine kettle of fish. Scaly, itchy fish that'll swim up to you on that next shift.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Sometimes we'll make the diagnosis ourselves, but most often we'll see the cases that fail the outpatient plan. That could be because the disease itself is worsening, or adherence to the plan could be better, or a new complication or irritant is present. Our biggest obstacle is the first: understanding where the family is coming from, helping them to feel heard, and tailoring a new plan to get them slowly to a better, steady state. Before we get into strategies for better trajectories, let's tailor our review of eczema to what we need to know to help our patients best. For our purposes, eczema is just another name for atopic dermatitis. It's a chronic, pruritic, inflammatory skin disease that most often starts in childhood, and it can persist to adulthood. There's lots of IgE floating around. It's found all over the world. It can run in families. That's as much epidemiology as we need to know for now. From a disease process standpoint, there are many things that can disrupt the skin as a barrier and cause an unending loop of itchy, scratchy misery. The stratum corneum may have some dysfunction in allowing for more water loss or reduced retention of moisture, or maybe there's some altered lipid ratios there. You may also hear about filaggrin, which is a protein that binds to keratin, and its problems that are involved in eczema. Cytokines, tight junction dysfunction, microbial colonization causing cytokine party time. We'll just leave it at that in terms of pathophysiology for now. Let's keep this clinical. Eczema is the itch that scratches. Dry, irritated skin. Two main presentations: infants and young children, and older children, adolescents, and adults. In infants and younger children, they usually start on the scalp, the cheeks, and the extensor surfaces. The rash is itchy and red and scaly. Usually you see this on the extensor surfaces, and it may progress all over the body. You may see a red, flaky baby clawing at his skin with little pudgy fingers, droopy-eyed and sad. One tip is that eczema often spares the diaper area. Why? Humidity. Also, think twice about your diagnosis if the red rash doesn't spare the diaper. In severe cases, the skin can weep with serous exudate and crust over. As the child suffers longer with chronically inflamed, dried-out skin that's excoriated, you'll see lichenification, usually by preschool to school age. In lighter-skinned children, this may be red or a pink rash. In children with darker skin, you'll see more violaceous or dark brown flaking. That is their inflammatory process. The darker the skin tone, the more likely you'll see hypopigmentation of the chronically irritated spots. The school-age child starts to show more lesions on the flexor surfaces rather than the extensor surfaces you see in babies. In adolescents and adults, you'll see more lichenification, more scarring, and more involvement of the hands. In anyone, if you see red or violaceous flaky skin in the armpits or groin, that doesn't really fit either. You may want to think again. Eczema is really a matter of dry skin. If it involves the relatively more humid areas of the body, think contact dermatitis or seborrheic dermatitis or even psoriasis. Those are the primary findings in eczema. Be alert to fake outs or incorrect previous diagnoses, but real talk, everyone usually knows what's up by the time they come to see you. It's just that common and chronic. Just a warning, sometimes patients may hold back what diagnoses they've been given, either to test you or because they don't believe it, or maybe they want you to come up with something else, or oftentimes, truthfully, because in the hustle and bustle and maybe feeling either intimidated or awkward, it just doesn't come up. So here are some other findings that may convince you that this is indeed eczema. Centrofacial pallor. Have you ever noticed that in a patient with eczema, whatever's going on in the cheeks or face, red or pink or even just a little irritated, that there's usually a ring of relatively unaffected skin around the mouth? It's called pallor, but it's really normal skin in this sea of angry red or violaceous mess. White dermatographism. This happens in all skin tones. Normally, when you think of someone who may have dermatographism, you think of someone with heat or cold stress, or even after exercise. You can literally write on their skin. A histamine-mediated response can cause a mild linear hive-like reaction. Not everyone, but sometimes people who have eczema may show that initial red line after drawing on their skin, but within 10 to 15 seconds, it turns white. It's fascinating. We think it's because of abnormal superficial cutaneous blood flow. Periorbital darkening, the so-called allergic shiners. This adds to that A to B picture. You may also see something called Denny-Morgan lines. These are exaggerated infraorbital folds. It looks like they have a small amount of edema under their eyelids, like an extra bag under their eyes. You may also see Hertoghe's sign, Hertoghe, Hertoghe's sign. In older children, it's a thinning of the lateral part of their eyebrows. And lastly, another indirect sign of this is eczema is scaling and cracking of the skin behind the ears, infraauricular and retroauricular scaling. Now that we're convinced that this is eczema, we should be thinking, why here and why now? I know, these questions are usually best left unasked, but here it's important because there is something that is just not working out for them at home. We can be of service to our patients by troubleshooting with them. Here are the top 5 reasons for an eczema flare to come to the emergency department.
Number 5.
Food and environmental allergies. What's new in what the child eats and drinks and wears and uses to wash his or her skin or clothes? It may not have bothered the child previously, but now it does. This is when a food and allergen diary is important for the family to keep. Give them an assignment to get a new notebook, fill it out, a page a day of everything the child eats, comes into contact with, whatever. This can then be brought to the PMD for the next visit. There are patterns that show up only after writing them down for a while. If your patient needs more support, you can always find some templates on the interwebs and print them out for them. It may help the PMD or allergist to further tailor allergy testing. It may also help the family to start to gain some more control over what feels like a helpless situation.
Number 4.
Infection. Many children with eczema are colonized with all kinds of bacteria that normally wouldn't be present in such high concentrations or even at all. Typically, it's a variation of Staph aureus, although any bacteria can colonize. Superinfection of dry, cracked skin in eczema is usually focal, and it's not usually dangerous. If it's widespread or disseminated, these children, of course, can become septic, but mostly not. Superinfection of dry, cracked skin is not cellulitis because the superinfected part is dry. It's minimally alive. Cellulitis, on the other hand, is infection of live, moist, deeper tissues. Superinfection is an overgrowth which causes more inflammation, scratching, then crusting, and weeping, then scratching, and then more inflammation. No other therapies will work until you unburden them of that bacterial load. How? If it's very mild, you can have them do dilute bleach baths. Most often we'll give an oral agent like cephalexin or amoxicillin. Again, not treating cellulitis, but an overgrowth. It's only part of the overall treatment.
Number 3.
Topical corticosteroid phobia. If we use topical steroids carefully, they're fine. The problem may be in that there may be other areas for improvement in the eczema care, but we put all of our faith initially in the steroids. The steroids will fix everything with no other changes. And of course, that leads to the rash coming right back or needing treatment after treatment. In a study by Lee et al. In JAMA Dermatology, this fear was found across cultures and countries. It's believed that up to 80% of caregivers have some concern about steroid use. They've learned all about all of the side effects and they just finally don't want them anymore. Now, it's good to know this so that we can address it head on. If they need it, they need it, and topical steroids are meant to not be this fast fix, but sometimes they're helpful to be a reset button to help all of the other interventions work.
Number 2.
Poor adherence to the regimen. I almost want to say this is number 1, but in a minute you'll see why. It's very hard to treat a chronic condition in a child, even in a healthy child. I'll say that again. It is so exhausting and demoralizing and frustrating and never-ending to treat a chronic condition in a child. Even if we're talking about an itchy, scratchy, rashy little angel who loves to be taken from his or her fun activities only to be lathered constantly in lotions and potions, it's still rough. It's important to ask open, supportive questions about fluid intake, emollient regimen, bathing regimen, all of those things. This is when it pays to slow down and listen, to show your intentions, but also to pick up on where we're falling down. The theme here is consistency. And if pressed, you'll often hear intermittent adherence to the plan. Of course, this has to be a daily dedication for it to work, or you just end up with more misery. It does get easier when the routine becomes a habit.
Number 1.
It's out of control now because, surprise, it's not a flare, it's a complication of eczema. What is the most dreaded complication of eczema? Something we just can't miss. Oh, did I hear you say it? Or did you whisper it? Eczema what? Eczema herpeta what? Eczema herpeticum. A superinfection of the herpes simplex on cracked, dried skin. It's almost always HSV1, the barrier is breached, and the herpes has cropped up in vesicles. We may see punched out erosions or hemorrhagic crusts. This is why we have to look at all of the skin when a patient comes in with any rash, especially eczema. Eczema herpeticum is a full stop. Admission for IVA cyclovir. This isn't a local herpes outbreak on normal skin that can get oral antibiotics and follow up. The reason the herpes infection is there is because of the conditions the eczema created, a break in the barrier. Remember, our first line of defense of microbes is our intact skin. The risk of dissemination is not high, but it is unacceptable. Admit these children even if well appearing. Other complications are infectious as well, but well tolerated as an outpatient, like molluscum contagiosum as a complication, or fungal infections, which may brew and not be obvious because their appearance can be muted when we give this dampening anti-inflammatory effect of the steroids. It can paradoxically suppress the immune response so that the fungus can stay among us. Even something as benign as Malassezia furfur yeast overgrowth may be a problem in non-reaction to standard treatment, especially on the scalp. So we've covered the what and the why not of eczema. That's all fine and well, but let's get down to how to deal with it. Eczema is like asthma. It's a stepwise approach in treatment. It's also a good case of where Aristotle helps us again. The whole is more than the sum of the parts. It really has to be a coordinated, concerted, and consistent effort. But when parents or caregivers understand the assignment, magic can happen. The skin is slowly rehydrated, the itching diminishes, the inflammation resolves, and maintenance therapy keeps the skin happy. So that's our goal. Again, you may be thinking, how is this emergency medicine? Well, the patient's here, the tuition is paid, might as well get the lesson. It also helps us to know what the next steps are so that this visit can be some value added to the patient. All right, here we go. First, hydration. I don't mean place IVs. I mean, the skin is a dry desert that needs irrigation to thrive again. Hydration from within is essential. The topical agents do not hydrate the skin. They emoliate. They just soften and seal. They treat the itch, but not really the dryness. Hydration only comes from, hydrating. You got to drink enough fluids. Keep that child urinating clear and colorless urine with constant hydration throughout the day. While we're hydrating the whole body, including the dermis, we have to emoliate to soften the dry skin and seal in moisture from the body itself. Now, this can be done with lotions, with creams, or with ointments. There's always a trade-off, of course. The easiest and most convenient are lotions. They usually don't leave a residue, and you can go about your day as long as you remember to use them. The downside is that lotions are mostly water. They evaporate quickly, and they leave your stratum corneum dry again very soon. They also contain more preservatives that can burn cracked skin and cause more of an itch scratch. So lotions are convenient, but they're better used with intact skin that is already in pretty good shape. On the other side of the spectrum are the ointments. They're actually the first ideal choice in emollients for eczema because they really do seal the deal. They have the highest oil content. They don't burn when you apply them to damaged skin, and they seal in that moisture. The downside is that your baby or child is a little ball of grease. They can rub off on clothes or furniture or people holding them. Ointments work the best, but you got to put up with the downside. Creams seem to be a good compromise between the two. They have a higher lipid content than lotions do. They seem to seal pretty well, and they're less greasy to the touch. They do, however, contain some stabilizers and preservatives, but less so than lotions. In my mind, lotions are for maintenance therapy in intact skin. Creams are for most moderate exacerbations, but you got to get through the day, and they mostly get the job done. Ointments are for severe cases when you just have to get that misery under control. I think this helps to talk to patients about because they themselves can titrate their own emollients at home in the future. They may be a little bit hesitant to use the creams or the lotions because those stabilizers and those extra preservatives can also cause some inflammation and some allergic reaction as well. So again, we're just trying to work with them with what their goals are and what they're willing to put up with. Steroid creams are a whole topic in and of itself, but for this discussion, I'll just share some specific recommendations for eczema. We have low, medium, and high potency categories, but the nomenclature can get confusing very quickly because one concentration of one med may be a higher potency of another med in a lower concentration. There's too much overlap here. So there's a table in the show notes to refer to, but let's just keep it simple. You can always start with a low potency steroid on anyone, anywhere, including the face, including infants, daily for a flare. When patients come in already on a steroid and it's not helping, doc, it's usually not so much an issue with the potency of the steroid. It's that the other components aren't being applied consistently. For that reason, if the patient's already on a topical steroid for eczema, I rarely bump it up because I don't want the primary physician to then feel that he or she needs to go even higher when the root cause isn't treated and they see them again. I try to stay out of longitudinal care plans that have been thought out well. Sometimes, when there is a need to go higher, I make sure I know the agent and its concentration and I verify where it belongs in the hierarchy of potency. As an aside, of course, systemic steroids are almost never used. When we talk about the amount of ointment or cream to put on, and this is especially important when we talk about topical steroids, we can use the term that dermatologists use, an FTU, a fingertip unit. It's the amount of ointment expressed from a tube with a 5 millimeter nozzle from the tip of the index finger in an adult to the first crease of the finger, the DIP. 1 FTU is enough to treat an area of skin twice the size of an adult's palm and fingers. So that's about 0.5 grams. In other words, 1 FTU is 1 fingertip and should cover the area of your outstretched palms and fingers. Now think about it. You can cover a baby's face with both of your hands, so that's 1 FTU. His chest is another FTU, and so is each arm. Each leg may be 1.5 FTU. Again, if 1 fingertip unit is half a gram, this can help you when you're trying to estimate how many grams of ointment to prescribe. My take is it's always more than we think. One tip that's important to remember is when the topical steroid is applied. It's typically 1 to 2 times per day for the low potency steroids. After a nice soaking bath, pat dry, apply the steroid immediately, and you want that to seep in deep. Then you can apply the emollient on top. You can continue to apply the emollient cream or ointment as many times as you want during the day, and that just continues to seal in the steroid and the moisture. Which brings us to when and how to bathe. The old thinking was that people with eczema should bathe only a few times a week because it dries out the skin. Again, it's all about hydration from within, emolliation, and sealing from the outside. The current advice is that people with eczema can and should bathe daily, but differently. Warm water, hypoallergenic cleanser specific for eczema, and no traditional soaps. The cleanser should be unscented, fragrance-free, dye-free. Typically, parents are really savvy about these. They can use bath oils that either mix with the water or form a skim top that coats the person when they get out of the tub. Oatmeal preparations can go inside the bath water. Some people will even add a cup of table salt to a full bathtub to soften the water and soothe the skin. This is especially helpful if the skin is cracked because hypotonic water will burn and irritate. Adding a quarter cup of baking soda to a full bath can help relieve itching as needed. All of these tips can be used daily. One last thing that has to do with bathing is an occasional bleach bath. Once a week, maybe twice. The idea is to decrease colonization of staph to prevent a flare. I usually recommend 1/4 cup of normal household bleach to the bathtub. Because most children take their baths with a tub half full, you can go up to 1/2 of a cup of just everyday household bleach diluted in that full tub of lukewarm water 1 to 2 times per week. The strategy with all this is to soak and seal, as they say. 10 minutes in lukewarm water, minimal scrub, minimal cleanser, then pat that skin lightly, leaving the skin still damp, just not wet. Add the steroid if using it, otherwise liberally coat that skin with emollient. If the child and parent do this, hydration by mouth, constant emollients, soak and seal every day, that's 90% of the way to happier skin and eczema. So you talk to mom. You tell her all about your great plan. You're feeling really good about how thorough you were. She then looks at you like you must have fallen off the turnip truck. She has made reasonable efforts to do all of that, and her toddler still looks like a red, flaky, itchy mess. Here's some next level magic that you can go to if you need it. Wet wraps. The idea is to keep the skin moisturized overnight, but you can do it anytime. Basically, you apply emollient generously, as you normally would do, then you add a layer of damp clothing, and then a layer of wet clothing. So it actually can be as easy as you make it. You can do this at any age, just modifying for comfort and strategy. You can use fancy gauze or something commercial, but truthfully, cotton tube socks or light cotton sheets or even light thermal underwear work really well for the first wet layer, and then pajamas or sweatshirts or sweatpants work really great for that dry layer on top. So, for example, let's say your patient is 9 years old and has a terrible, dry, flaking rash with even lichenification on bilateral antecubital foci. You put in the cream or the ointment, it's applied everywhere there's a rash. You take a long cotton tube sock, you cut off that toe, maybe even fashion a little cutout for that thumb to rest in. You soak the cotton sock in regular water, lukewarm water, wring it out, and then you place it over the arm. Then you can dress with another dry sock and off to bed. You can do this with any part of the body, preferably with breathable cotton and preferably after a bath. If this is done for a week or so, there will be significant improvement in the eczema flare. Plus, it's cheap and you can do it as often as you like. This will get you through some tough presentations. One last bit to mention, mostly because we see patients again and again, and it's good to know what the next steps are. At this point, if the eczema is not responding to due diligence and the patient has not yet seen a dermatologist, then it's time. Most eczema care can be managed by a family medicine doctor or a pediatrician because it's pretty straightforward and just needs persistence. However, once we start talking treatment-resistant presentations, it's really time to get the experts on board. As we mentioned, topical steroids can get pretty intense, and I personally leave the higher tier adjustments to the doctors who will be seeing these patients over time. They may step it up to topical calcineurin inhibitors, which can be steroid sparing. There are side effects, so again, I'll defer to the derms. Phototherapy can be used. It's typically reserved for adolescents and adults only because it can freak kids out. It's a large box with narrow band light bulbs that emit UVB light. You stay in there for a number of minutes at a time, and there can be options, of course, for the older child and adolescent. Then you have all of the hardcore systemic agents. All of them are off-label: cyclosporin, methotrexate, azathioprine, etc. In summary, it's all about hydrating from within, addressing the flare with steroids, softening the skin with emollients, soak and seal, and maybe even a little wet wrap from time to time. The point here is to have a working knowledge of the array of options so that you can troubleshoot with patients and parents to figure out what they need right now. Sometimes it's a review, sometimes it's an overhaul, and sometimes a few tricks of the trade to make the whole more than the sum of the parts. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.